All right, good evening, everyone. So I wanted to welcome everyone to this year's first presentation of our 2023 evening speaker series. I wanted to thank all of our valuable industry partners for being here today. We really do appreciate the time that you take out of your day to spend it with us. And we would not be able to accomplish our mission without your support. So here's our agenda for today. There will be time for questions after the presentation. And the event is also being recorded and will be uploaded to our event website for future viewing. For our event tonight, we'll have Dr. Natalie Vokes of MD Anderson Cancer Center. Dr. Vokes is a thoracic oncologist with expertise in the application of computational approaches to clinical oncology. She received her bachelor's in chemistry from Williams College, graduating summa cum laude, and a master's of philosophy in history and philosophy of science from Cambridge University. She attended Harvard Medical School before completing her residency in internal medicine at Brigham and Women's Hospital and her fellowship in medical oncology at the Dana-Farber Cancer Care Oncology Fellowship. Her postdoctoral research in Dr. Eliza Van Allen's lab focused on genomic predictors of response to immune and targeted therapies. She is now an assistant professor at MD Anderson in the Department of Thoracic, Head and Neck Oncology with a joint appointment in genomic medicine. Her research focuses on the understanding of tumor intrinsic determinants of tumor immune microenvironment, development of novel predictive algorithms for immunotherapy response, and dissecting the evolution of resistance to therapy. She's a current Mark Foundation Damon Runyon Physician Scientist Scholar, and she was also a recipient of the Conquer Cancer Foundation Young Investigator Award and has presented her work at numerous national and international meetings. Dr. Vokes pre-recorded her presentation, but will be joining us halfway through for question and answer.
Good evening. Thank you to the organizers for the invitation to speak with you tonight. I'm sorry that I'm not able to be there in person. I'm at the AACR meeting in Orlando, but I am looking forward to the discussion during the Q&A portion of the talk. My name is Natalie Vokes. I'm an assistant professor of thoracic oncology and genomic medicine at MD Anderson, and my work focuses on using computational techniques to look at molecular data sets and try to understand why different patients do or don't respond to therapy, with a particular interest in immunotherapy. So I'm very honored to be talking to you tonight on tissue-based predictors of immunotherapy. These are my disclosures. So the high-level background behind this talk, I think, is familiar to everybody in the audience, which is that outcomes across many cancer types have improved with the advent of immune checkpoint inhibitor therapies, and these therapies uniquely have offered some of our patients the opportunity for long-term durable disease control. But the problem is it's only a minority of patients who benefit, and resistance, both primary and acquired, remains a key clinical challenge. And so the research question that this has posed is, how can we understand predictors of response and resistance, with the idea being that this understanding is crucial to developing therapeutic strategies to improve outcomes, and in the short term to deploy the therapies that we do have to the patients most likely to benefit. So to give you an outline for my remarks tonight, I was going to start with providing a general framework of the immunotherapy biomarker landscape, as well as the most promising results to date. I'll then focus on some tumor intrinsic predictors, in particular tumor mutational burden, or TMB. I'll talk about tumor extrinsic predictors, so immune-related predictors that have been described to date. And then we'll close by focusing on immunotherapy biomarkers in the context of combination therapies. So I think any discussion of immunotherapy biomarkers is helped by anchoring it on some kind of framework for what we think is the biology underlying immune checkpoint inhibitor response. And there's a lot about this that we still don't understand, but the best framework that we have to date is the tumor immunity cycle, which is depicted here. And without going into a lot of details on this graph, fundamentally what we think happens is that there are tumors that produce cancer-associated antigens that are basically peptides that are distinct from normal peptides and are derived from cancer mutations. These lead to T-cell activation and ultimately T-cell trafficking into the tumor, where T-cells are then engaged in an anti-tumor immune response and immune-mediated tumor cell death. And this is done via the pathways and cytokines that I've highlighted here. So when I think about immunotherapy biomarkers, I think it's helpful to divide them into tumor intrinsic predictors, which describe features of the cancer that are either immune activating or immune suppressive, and tumor extrinsic predictors, which describe features of the immune response that either associate with an effective anti-tumor T-cell response or not. Tumor intrinsic predictors that have been described to date include features of mutational burden or neoantigen load, including tumor mutational burden and other variants thereof. Genomic loss of neoantigens, which is the opposite, has been described as a negative predictor. Loss of antigen presentation, such as beta-2M or HLA loss, are also associated. And then there's been a large effort to associate single gene mutations with either immune activating or generally immune suppressing phenotypes, some of which are described here. In terms of tumor extrinsic predictors, markers of T-cell activation, signatures for interferon gamma or cytolytic T-cells have been associated with positive response. On histology, evidence of T-cell infiltrate or very inflamed tumor has been associated. TCR diversity or diversity of the T-cell receptor has been associated in both positive and negative directions. And then negative associations have been made between the presence of more immunosuppressive populations, such as myeloid cells, and histologic evidence of cold or immune-excluded tumors have also been associated with a lower likelihood of immunotherapy response. So I won't have time to talk about all of these today, but I did want to go into more detail on a couple of the key ones. And I thought it would be helpful to start first with tumor mutational burden, since this is the predictor that's really been discussed and researched the most. So this association was made in the very early days of immunotherapy. And as early as 2014, there were several studies that showed that melanoma tumors that responded to anti-CTLA-4 therapy generally had higher numbers of somatic mutations or a higher TMB. And this was then shown in a number of other contexts, including in the treatment of non-small cell lung cancer. This was corroborated by extension in the association between mismatch repaired deficient colorectal cancer with a better immunotherapy response. And since these early studies, again, this has been shown in a number of different contexts, kind of across the board, not in all cancer types, but in many cancer types. And so this led to a lot of enthusiasm in trying to move TMB to the clinic. And in fact, TMB became an FDA-approved biomarker several years ago. But I think that despite the wealth of literature on this topic and despite the FDA approval, the uptake of TMB in the clinic has been somewhat low. And my take on this is because even though TMB is a very consistent association with outcome, it's not very clearly a very good biomarker. And there are a couple major issues. So one of the issues that gets discussed the most is that TMB produced by different panels will have different values. So there's kind of technical variation in the TMB values. And this is true, but I think is actually a somewhat surmountable issue. The more intractable biological issue is that I think TMB is a continuous variable, and selecting a cut point is not a trivial matter. We looked at this in 2019. You can see some figures from this paper, and we basically looked at the rate of response as we increased the TMB threshold. And you can see on the left that as our TMB threshold went up, the rate of response also went up. But this raises the question as to whether we're seeing this increased rate of response in these medium cutoffs really because we're starting to enrich for these highest TMB responders. So we also looked at the rate of response basically in different TMB groups. So rather than just increasing the threshold, we'd said, okay, if your TMB is between the 50th and the 60th percentile, what's your rate of response? And what you can see here when we did that is that the rates of response in the mid-range here are very similar. And it's only really in the very lowest TMB and in the very highest TMB groupings that we see a clear difference. This was a somewhat small cohort, but the results were reproduced in a later analysis published just last year in JAMA Oncology, and we've also seen this in a number of other contexts. This is from blood TMB values from the oak and poplar data sets, and you can see again kind of the same thing, that as the TMB threshold goes up, the hazard ratio here goes down. So putting all of this together, TMB becomes more predictive as your TMB threshold goes up. But the issue with applying this to the clinic is that none of us want to imply a biomarker that leads us to exclude 90% of our population, many of whom have meaningful response to immune checkpoint inhibitors. So we don't want to deprive patients of the therapy just on the basis of this. And the second point is that even at its best, so even in this greater than 90th percentile group, the rate of durable clinical benefit is still only 50%. So TMB, even at its best, is still only right half of the time in terms of picking out patients who will or won't respond. So I think all of these features limit the utility of TMB, even though if you see somebody with a very high TMB, it certainly is encouraging. Now, this data is not unique to lung cancer nor to these data sets. So if you look at the data that underlie the FDA approval, you can see that they looked at TMB cutoffs of 10 or 13. And I will note that this is a fairly small cohort. It's smaller than the data that I just showed on the previous slide, and it also includes a number of different cancer types, some of which are present only in very small numbers. And you can see that with a TMB cutoff of 10 and 13, there is an increase from 29 to 37%. And strikingly, if you look at the response rates for the patients in between these two values, the response rate is only 13%. So what this tells us is that when we have a TMB threshold, let's say of 13, this still doesn't tell us how a patient with a TMB of 12, 11, or 14 is going to do. It's probably those highest TMB patients that are driving that higher rate of response that we're seeing there. The other thing to point out about TMB is that we've talked a lot about how we can apply it in the clinic, and we haven't talked very much about why it is that TMB seems to capture biology. Is it something about just more mutations and a higher likelihood of a neoantigen response, or is TMB a surrogate for some other mutational process that's important to the development of an anti-tumor immune response? There was an interesting paper published in the New England Journal in 2021 that looked at this to some extent. They took patients with a number of tumor types and then stratified by TMB greater than or less than 10. And you can see that the high TMB patients do better, as you would expect. What they then did is pulled out whether patients had evidence of a pol D or a mismatch repair mutational signature. And what you can see is that the benefit was really limited to those patients, whereas patients with a TMB greater than 10 without one of those mutational processes did as badly as the patients with a TMB less than 10. So this raises the question, is it something about the presence of these mutational signatures that's important? Is it that these mutational signatures associate with the very highest TMBs? Or is there some other biology going on here that we haven't yet described? When we looked at this in lung cancer and we looked at whether TMB was predictive in the context of smoking history, you can see that increasing TMB thresholds do associate with a higher rate of response in patients who have a history of smoke exposure. With patients who did not have any smoking history, even as we got into the highest TMB values, you can see that the rates of response are not going up at all. So there's some association between TMB with outcome only in the context of a smoking history and probably a smoking mutational signature. So moving on from TMB, the next most active area of research has been to try to look to see whether single genes associate with different immunotherapy outcomes. And to date, I think the best studied and the highest level of evidence exists for looking at driver oncogenes in non-small cell lung cancer. So the oncogenic drivers in non-small cell lung cancer are shown here in this pie graph. The most common is KRAS, but the most significant is EGFR in terms of targetability. And there have been several retrospective multi-institutional cohort analyses that have looked at the rates of response given these different mutations. And in general, what we see is that the likelihood of radiographic response and conversely, the rate of progressive disease increases as you get into the never smoker fusion related genes. So EGFR, ALK, RET, ROS1, and to some extent HER2 all associate with higher rates of progressive disease compared to the others. And you can see this in this Kaplan-Meier curve. There was another study that was published by my colleague Marcelo Negrão in 2021 that showed very similar results. So KRAS mutation represents kind of a baseline. You can see that EGFR, ALK, RET all associate with worse progression-free and overall survival. Interestingly, BRAF, and this is very much true in the MD Anderson cohort, BRAF actually associates with reasonably good outcomes, and MET is kind of in the middle. So in our cohort, MET did not look as good compared to KRAS and BRAF. In this cohort, which was a cohort led by a group from France, MET actually looked okay, but still a little bit worse over time. And, you know, the interesting question behind these associations is trying to disentangle why is it that these driver genes associate with poor outcomes. Some of it may be that these are less associated with features that we think are predictive. So we know that all of these tumors associate with much lower TMB, whereas KRAS and BRAF are more smoking associated and so more likely to carry a number of mutations. It is also the case that PD-L1 is probably a bit lower in some of these tumors. But it also may be the case that these features are not as predictive in the context of driver mutations. So I showed that TMB was probably not as predictive in the context of never smokers. We found the same trend when we looked at driver mutations specifically. And PD-L1 may also be less predictive in these contexts. So seeing a patient with a high PD-L1 but an EGFR mutation does not validate the use of immunotherapy monotherapy. Patients with EGFR mutations, even with a high PD-L1, should still be given a TKI as their first-line therapy rather than a trial of immune checkpoint inhibitors. Other single genes that have been discussed in lung cancer are the STK11 and KEAP1 genes. There have been a number of publications showing that these associate with worse outcomes, both in the context of IO monotherapy as well as IO plus chemotherapy. It is worth emphasizing that this has not been true in all cohorts. So there was a recent publication in Annals of Oncology just this year that showed in a clinical trial data set that STK11 and KEAP1 mutant patients still benefited from the use of pembrolizumab over chemotherapy. And some of this heterogeneity in the reported clinical outcomes may come from the effect of co-mutations. So there is a nice multi-institutional retrospective study that showed that STK11 and KEAP1 associate with worse outcomes really only in the context of KRAS mutations. In the context of KRAS wild-type tumors, these genes had no negative effect. There was another study that came from Penn several years ago that was smaller that suggested that p53 may further modulate this association. So if you have p53 in addition to KRAS and STK11, that may be somewhat protective compared to if you just have STK11 and KRAS alone. So when we see data like the previous slide, looking at outcomes between STK11 and KEAP1 and immunotherapy, really, I think at this point we need more of the co-mutation data to interpret if we're seeing differences in biology or not. I think fundamentally there's some interesting signal with these genes that I've mentioned, but in general, the analysis of single genes with immunotherapy outcomes is limited in a couple ways. The first is that a lot of mutations are actually just associated with TMB. So if you have a more mutated tumor, you're more likely to see mutations in genes that are big and frequently mutated. A classic example of this is Titin, which is TTN, and several other lung cancer genes are often implicated in immunotherapy response, but are probably just TMB surrogates. The other piece of it is that these single gene correlates of response probably have fairly weak associations. There's a lot of additional complicated biology that's involved, and consequently, finding these associations is very much dependent on how big our cohort is. And what you can see that for the most common mutations, our cohorts are big enough to detect them. But for less common mutations or ones that have a weaker effect on outcome, we're still very much underpowered to see these genes with any kind of significance. And so ongoing efforts to build bigger cohorts to gather more data will help in validating some of the associations that have been published and also in identifying new biology. So turning now away from tumor intrinsic features to tumor extrinsic features, as a reminder, this is really focusing on this aspect of this immunity cycle. So is there evidence that T cells have infiltrated into the tumors and that there is active T cell activity and activation of these different pathways? And I think it would be remiss not to start by talking about PD-L1. This is best established in lung cancer, and we use PD-L1 in a much more nuanced fashion than in other tumor types, where usually PD-L1 is simply looked at a threshold of 1% or absent. PD-L1 most likely represents, again, evidence that there has been this tumor T cell infiltrate and activation of these pathways, and it can indicate that there are immune cells that are primed to be re-engaged with the presence of immune checkpoint inhibitor therapy. But I think, like TMB, PD-L1 has its limitations, and in particular, PD-L1 is most likely a continuous biomarker, again, at least in lung cancer. So a nice retrospective study looked at applying higher PD-L1 cutoffs and found that if you increase your PD-L1 threshold to 90%, the rate of response goes from 30% to 60%. And here you can see that if you compare the PD-L1 90 to 100%, these patients have much better progression-free survival than even those other PD-L1 high patients. And when we looked at how predictive PD-L1 is compared to TMB, you can see that the shape of this receiver-operator characteristic curve is very similar. Both of these offer some marginal benefit over baseline with an AUC of 0.6 in both, and neither of them have a very clear inflection point for how you would pick a cutoff. So while our practice has been to use cutoffs of 1% or 50% in lung cancer, it is probably worth emphasizing that, again, that 50% benefit, the benefit in the 50% group is probably in part due to enriching for the very highest PD-L1 patients, just as we saw with TMB. Now, another aspect of immunotherapy research has been to try to look at expression signatures. And the idea behind this is twofold. So the first is that when you look at expression signatures, it may be that we can identify new biological subtypes that we hadn't been able to capture by looking just at the mutational profile. A great example of this is small cell lung cancer. So small cell lung cancer mutationally looks very homogeneous. All the patients have P53 and RB1 mutations, or nearly all. But when you look at the expression profiles, it actually turns out that there emerges 4 somewhat distinct small cell lung cancer subtypes, and these are characterized by the expression of ASCL1, NeuroD1, and POW2F3. Now, interestingly, there's a 4th cluster that's marked here as the I, and this cluster associates with a higher level of immune infiltrate and also associates with more specific benefit to immune checkpoint inhibitor therapy. So the idea here, this is kind of proof of concept, that when you look at the expression profile, you can unpack different biological phenotypes, but it also allows you to capture the immune profile of the tumor, since in addition to getting expression data from the tumor cells, you can also derive expression signatures from the infiltrating immune cells. So in a number of different cancer types, there have been implicated a number of expression signatures with immunotherapy outcome. The best characterized to date of these is the interferon gamma signature, which is also called the GEP. This just looks at the expression of several different interferon gamma related genes, and the early study showed that higher interferon gamma expression associated with a higher likelihood of response to immune checkpoint inhibitors. There have been a number of similar signatures published. Here you can see a correlation matrix that shows that a lot of these signatures are capturing the same biology. Here you can see a heat map again showing that a high GEP marks out very similar samples to the interferon gamma signature, chemokine signature, and other published signatures. So a lot of these have different names, but they're fundamentally looking at the same biology. And I think that expression signatures are interesting. I think that they do capture new biology, and that some phenotype of the immune system is actually very important in trying to understand, is this an inflamed tumor or not? There are a couple issues with expression signatures, though. So the first is that there's a lot of technical variability between how RNA-seq data is processed from cohort to cohort, and that technical variability can lead to big differences in the expression signature values. So it is important that these approaches are standardized and harmonized when we're comparing across different data sets. But the other issue, which is I think less surmountable, is that a lot of these signatures get reported in an initial data set, and then they don't really get validated in the initial publication. However, when the data sets are applied, the signatures are applied to new data sets, a lot of times they really don't look as good as they did in the initial publication. This was a very nice paper that was published in 2021 using RNA-seq data from several different cancer types, including bladder cancer and others, and they attempted to derive a new predictive expression signature, which is shown here in the purple. And then very helpfully, they compared this to a number of other published signatures. And then they validated all of these signatures in a test data set. And I have to commend the authors for being very honest about the fact that their signature really didn't look as good in this validation data set. But the other thing to point out is that none of the signatures looked that good. So all of these previously published signatures, including the GEP and others, all of them have AUCs of right around 0.6. And again, just to remind you, this is what TMB and PD-L1 looks like. So it's not that any of these are uniquely bad, it's just that none of them ultimately in new data sets or new context are very predictive. All of them are capturing some relevant biology, but how helpful that is to clinical decision making is really hard to say. One of the ways forward is probably to integrate tumor intrinsic and immune features. A very simple example of this is just to take TMB and GEP, and this was a publication in 2018 where they did that, and you can see that if you look in this quadrant of patients that have high TMBs and high GEP expression scores, these are patients that have higher rates of response. It's worth noting that even patients that are low on one of these axes do still have some meaningful response, but not as significant as in that highest group. And this was shown in a prospective clinical trial in Keynote 495, where they stratified patients again along these two axes. And you can see that across these different treatment arms, the patients that are TMB high, GEP high, do have the highest highest rates of response. Another more sophisticated way to integrate tumor intrinsic and extrinsic predictive features is using machine learning and radiomics. So the idea here is that when you look at a radiographic scan, there may be more biology embedded in there than what we typically captured simply by doing 2D measurements. You know, if you have computational radiomics, that may capture features of a more immune-infiltrated tumor, markers of inflammation, higher TMB. All of those things may actually manifest on the radiographic image. So we did an initial study of this. This was led by my colleague Jia Wu, who's an expert in radiomics, and we took MD Anderson patients and then basically built clinical and radiomic predictive models for immunotherapy outcomes. And what we found is that both clinical and radiomic features could identify a high risk and a low risk group. And then if we integrated these models, this ended up being the most predictive. So patients that had low risk radiomic scores as well as low risk clinical scores, they did the best, whereas patients that were high risk on both axes had the worst overall survival and the worst outcomes. Another example of this, again, kind of slowly integrating more and more data types, capturing more and more different orthogonal biologies, was a pilot study published from Memorial Sloan Kettering, and they integrated radiomics. They also included histopathology images, as well as genomics, TMB, and clinical features. And then again, they built individual models, and then they integrated all of these models together. And you can see the predictive value of the individual models is kind of hovering around 0.6, which is where we are tapping out in a lot of cases. And then when they integrated these different features together, that pushed the predictive value to 0.75, and in some cases up to 0.8. None of these approaches are free from the problems I've mentioned before, so all of these models need to be heavily validated in new data sets and in new contexts to verify that they truly are as good as they seem. But this may be a way to integrate complementary biological features to, again, kind of more selectively pinpoint those patients who are going to respond. So if we put all of this together, you know, where have we gotten at this point in time? I think the last 5 to 10 years of research have done a really great job in implicating a number of these different pathways. And we can see that some of these features are consistently shown now in study across study. But I've tried to emphasize that I think that the clinical utility of a lot of these features remains low. And it's not that the research is bad, it's that the predictors of immunotherapy response are very complicated, and any single feature that we've identified to date really doesn't seem to be capturing the full extent of that biology. So in thinking about how we move forward, I think it's also worth asking ourselves, what are we trying to achieve with these biomarker analyses? If we're simply trying to predict and prognosticate, so, you know, to say, will our patient respond or not respond to immunotherapy, then I think the way forward is going to be the multimodal integrative modeling approaches that I've described. But I think it's also worth emphasizing that we could and should be asking different questions. So nowadays, we no longer live in a world where we're deciding should a patient get immunotherapy or not. At least in lung cancer, almost all of our patients do at some point. So the question is not should a patient get it, but rather in which regimen should we be giving immunotherapy, and how do we best select the most appropriate regimen for our patients? And this focus on treatment-specific outcome predictors is a little bit different than the general predictive prognostic modeling that I've described, but could build models that are more directly applicable to clinical practice. And then lastly, even despite all of this research, we still have drugs that fundamentally work in about 20 to 30% of patients, more in melanoma, less in other tumor types. And so the question is, how can we use this kind of research to build better drugs that combat some of the limitations of the drugs to date, or to use the drugs that we do have in more rational combinations to improve immunotherapy outcomes? So in the last portion of the talk, I wanted to focus in on this middle section and talk about my take on combination therapies and how we think about selecting them. And I'll anchor this discussion in frontline in non-small cell lung cancer, which again is where I spend a lot of my clinical time. And so just to provide a quick overview, one of the challenges in frontline non-small cell lung cancer is that excluding these driver positive patients, we now have a number of approved immunotherapy regimens, including immunotherapy monotherapy, chemo plus pembro or cemiplimab, chemo plus dual immune checkpoint blockade, as well as dual immune checkpoint blockade alone. And we typically use PD-L1 stratification as a way to kind of narrow down some of these choices, but even within these different PD-L1 groupings, there are a number of choices. So you can see for PD-L1 greater than 50%, we can choose pretty much any of these regimens. For PD-L1 greater than 1%, we can choose any of these regimens, though most people will avoid PD-1 monotherapy. And even for PD-L1 less than 1%, we now have the choice between different chemo combinations, and some of us off-label will still give immune checkpoint doublet for the PD-L1 low patients in whom we think that chemo is not the best option. So what this leads us with is a big mishmash. And part of the problem in trying to make a choice between these different regimens is that the clinical trials that were used all used chemotherapy as a control arm. So the result is that when we're trying to choose between pembro mono versus pembro plus chemo or others, we don't have clinical trial data to guide us because all of these clinical trials compared the immunotherapy to the chemotherapy, which is not the decision that we're making anymore. And I think the fundamental question underlying this is, when we give combination therapy, is this a synergistic effect or is it simply an additive benefit? And there was very nice simulation data that came out a couple of years ago to suggest that this is potentially more of an additive benefit rather than synergy, even though when people talk about the combination, a lot of times people talk about synergy. So the framework for an additive benefit is simply that if you have two drugs, A and B, that have different mechanisms of action, the population of patients that respond to A and B are going to be slightly different. There may be some patients who respond to both, but there are going to be patients who only respond to A or who only respond to B. And so the idea is that if you give drug A and drug B together, the outcomes are going to improve simply because you're expanding the number of patients who benefit from therapy. But this is not synergy, this is simply just an independent action or an additive benefit. And the group that looked at this simulated whether this is taking place by taking published clinical trial data, looking at the efficacy of drug A and drug B, and then modeling what the survival curve would look like if you had this mechanism of independent action. And here you can see on the somewhat busy slide the results of this. So the blue line represents the observed combination PFS data, and the black line represents what they got from their simulations. And you can see that in basically all cases, their simulated model and the observed data actually overlapped precisely. And in some cases, it actually even looked a little bit worse than what you would expect from independent action. So this simulated data really suggested that what we're seeing in clinical trials represents the use of two different drugs, but not necessarily any synergistic benefit. So we looked at this in a lung cancer cohort to see whether we were observing any evidence for synergy or whether we could kind of more precisely carve out what was the role of chemotherapy in this context. So we used a cohort of non-small cell lung cancer patients from MD Anderson. And then we very simply looked at whether outcomes for patients treated with immune checkpoint inhibitor monotherapy were different than those treated with immune checkpoint inhibitor and chemotherapy. Here you can see the PFS and OS data, and fundamentally, these look very similar. So there's no particular benefit over the long term from the addition of chemo, either to PFS or to OS. When we looked at PD-L1 stratification, you can see that, again, kind of no difference. There's a little bit of a trend here towards the IO mono group looking a little worse than the IO chemo group in the low PD-L1s. And I will emphasize that we had very few with PD-L1 negative patients who were treated with IO mono. But fundamentally, kind of across these groups, the outcome seems to be pretty similar. And when we looked at PD-L1 as a predictor in the context of IO mono versus IO chemo, you can see that in both subsets, really it's the patients with the high PD-L1 who have the good long-term PFS. And this suggests to me that the addition of chemo is not really likely to change whether or not you're an immunotherapy responder. Your long-term outcomes are driven by that underlying biology, which again is kind of represented by PD-L1, and chemo doesn't change whether that interaction happens or not. We also looked at whether sequence of therapy matters. So if you have a synergistic relationship, you would imagine that there would be some benefit to giving immunotherapy with chemotherapy together. Whereas if it's just an additive benefit, then you could theoretically start with the immunotherapy, give the chemotherapy after, and achieve the same long-term results. So we stratified patients by whether they had been treated in combination or in sequence. In the green line, you can see those patients treated with IO mono alone. In the purple line, you can see those patients who were treated with immunotherapy followed by chemotherapy. And in the yellow line, you can see the patients who were treated with immunotherapy and chemotherapy at the same time. And what you can see here again is that the overall outcomes look very similar, with no particular long-term benefit from one approach versus the other. Now, that's not to say that the chemotherapy isn't doing anything. So when we looked at the risk over time, these are kind of more complicated statistical graphs, you can see that in the early phases here, in first 3 to 6 months, there is a bit of a benefit towards treating with chemotherapy compared to immune checkpoint inhibitor monotherapy. This was not true for overall survival, but it was true for progression-free survival. And I think this is what you'd expect. You know, if you have this independent action model and you're treating with drugs that work differently, you would expect that your upfront progression rates should be less when you're giving multiple drugs than when you're giving just one drug that only 30 to 40% of patients respond to. So the question then becomes not who's an immunotherapy responder, but who is at highest risk from early progression. And can we identify those patients so that we can make sure that we give chemotherapy in those patients and ensure that we don't have somebody who never makes it to their second line of therapy. So we looked to see a number of clinical features associated with progression. These looked pretty similar to in the IO mono versus IO chemo groups, but there was a trend towards smoking status being preferentially worse in the IO mono group, and kind of a trend towards histology looking a little bit different as well. And then we looked at genomic features that associated with both 3-month progression and PFS. And when we looked at the 3-month progression, the top row is in IO mono and the bottom row is in IO chemo. You can see that STK11, HER2, and cell cycle amplifications all associate with worse 3-month progression in the IO mono group, but there's really less that comes out in the IO chemo group. And this again is probably because you're just treating with more drugs, and so there's fewer specific predictors of response. Interestingly, when we looked at overall PFS, most of these genes were not differentially predictive except for CDKN2A and CCND1. So these are both cell cycle genes, and it looked like alterations of these genes actually associated with worse outcomes to IO chemo than they did to IO mono. We dug into this a little bit deeper in our cohort as well as in a validation cohort, and interestingly, the results seem to hold. So you can see that IO mono patients with CDKN2A alterations do a little bit better than the IO chemo patients that have this. And we saw very similar results in a completely independent cohort from Mayo, where again, the IO mono CDKN2A loss patients look much better than the IO chemo ones. We did look to see whether this was driven primarily by mutations in these genes or copy number loss, but ultimately weren't really powered to kind of verify that aspect of it. Now, the interesting thing is that there have been other publications that have implicated alterations in cell cycle genes with differential immunotherapy efficacy. A meta-analysis from Charlie Swanton's group implicated both CDKN2A and CCND1. We had a study published in 2018 that also identified copy number alterations in these genes with a higher likelihood of progressive disease. And this has been shown in a number of preclinical papers as well, looking at CRISPR knockouts or inhibition in vitro and in vivo systems that have also suggested there's some relationship between the cell cycle and immune checkpoint or anti-tumor T cell activity. So TBD on this, but there is some interesting signal that's arising here. So moving back then to the clinical question, the whole point of this analysis was to say, look, it may be the case that immunotherapy and chemotherapy are not synergistic, but there may still be some benefits to treating high-risk patients with the combination approach. And how can we use the analyses we've just shown to flag those patients? So we built a predictive model for IO mono versus IO chemo. And what you can see is that in the IO mono group, a number of features emerged, including liver metastasis, higher metastatic stage, and low PD-L1 as all being associated with worse outcomes. And this model, had an AUC of 0.7, so a little better than what we've seen, but I think, fundamentally kind of helps give you a little bit of a heuristic for who are those high-risk patients. And when we looked in the IO chemo group, you can see that these features were not really as strongly predictive other than a low PD-L1, which is consistent with the fact that chemo is probably diluting out some of these response associations. And here you can see compared, again, the IO mono model is a little bit more predictive than the IO chemo model. So putting all of this together, my high-level take on immunotherapy biomarkers is that TMB and some of the other approved biomarkers have some but limited utility. Tumor intrinsic features are not deterministic. So presence of high TMB, the presence of STK11, these are associations, but they don't say conclusively that somebody will or won't respond. And I see this as arising from the fact that these are embedded in complex intratumor and intratumor immune biology that remains poorly understood. I think integrating tumor intrinsic and immune features may better capture an IO-sensitive tumor phenotype. And fundamentally, I think in the absence of deterministic biology, immunotherapy biomarkers should be analyzed around relevant treatment decisions, questions around biological discovery, or novel therapeutic strategies. So with that, I'd like to highlight my mentors and collaborators. I thank you for your attention, and I look forward to your questions.
Hi, Dr. Vokes. Can you hear me?
Yes, hello.
Hi. So I wanted to open it up for questions. Thank you again for recording that and for being with us tonight. So I wanted to open it up to any questions from our audience. Yes, Dr. Beavers.
Yes, Dr. Beaver, a retired oncologist here in Omaha. Nice to hear you talk. I've worked with many researchers at MD Anderson the last 20 years. So, basic question, with the approval of precision medicine arrays, if that's the right terminology, either specific mutations or groups of mutations, that seems to be coming more and more into general clinical practice in the community. Your talk sounds very interesting, but seems to be still in the realm of academics, basically. So how does your research end up coming to the community in central Nebraska eventually?
I think that's a very fair question. So my clinical practice, as I disclaimed at the beginning, is lung cancer, and I think lung cancer is one of the better examples of a solid tumor where precision oncology is in general practice. But I think immunotherapy is kind of the exception to that. So, I very deliberately excluded drivers. I think we have a lot of good data that driver mutated lung cancers behave differently in the context of immunotherapy. And the whole rest of the talk is to say that all efforts at precision immuno-oncology have mostly failed to date. But I think it is important to know the exceptions for immunotherapy. We see a lot of patients who come to us in clinic. This is less frequent now, where providers think that if they have a high PD-L1, they can start with chemoimmunotherapy in everybody. But the reality is you really shouldn't do that until you know their driver mutation status. So I think knowing who to kind of funnel out of your immuno-oncology is very important still for general practice. I think for everybody else, I would simply say I wouldn't let anything like a low TMB or something like that exclude you from an otherwise appropriate trial of immunotherapy, because I think none of the other things that we hear talked about are ready for prime time.
Yeah, thank you. Interesting to hear that. There's been so much intensity about TMB.
Yeah. I think that's exactly right. I think TMB got a lot of attention, and it's not to say that it's not real. We see the same association in study after study after study. That doesn't mean that it's a good clinical biomarker. It's not.
Yeah, thank you.
All right. Do we have any other questions from the audience? All right. Well, seeing none, thank you so much, Dr. Vogts, for sharing your time with us and sharing your expertise. We really do appreciate it.
Absolutely. Thanks for the invitation. And I'm sorry I couldn't be there to meet with you in person, but hopefully another time.
Thank you. All right. So with that, just wanted to also share information about our next few events. Our next evening speaker series will be regarding the topic of theranostics. Then our annual mid-year review, previously known as our ASCO review, will be Saturday, June 24th. And then we have 2 more evening speaker series throughout the year. So we hope that you'll be able to join us for those as well. And with that, I wanted to thank everyone for your participation tonight. I hope that you've enjoyed your time with us, and I want to thank our speaker again, as well as our industry partners and their valuable participation today. Thank you, and enjoy the rest of your evening.